Chapter 30, The Child with Integumentary Dysfunction. These are different types of lesions, and I've underlined the ones that are the most common, that you'll hear the most common terms. You really do need to know these. You need to be able to communicate with other healthcare providers who are going to be using these very specific terms. So you need to know them, and like I said, I've underlined the ones that are the most commonly used. Now, factors influencing healing when you have wounds of the skin. A moist, crust-free environment is going to be the best environment for healing. So good nutrition is important. We need the protein and the nutrients for making new healthy tissue. Lowering stress is going to make our bodies work better and things heal better. Avoiding infection in the site is going to enhance healing. When there's other diseases, if the child has some other chronic disease, that makes healing harder. The body has trouble doing that many things at once. And circulation, we need to be circulating adequate nutrients and oxygen to the affected area for healing. Wound care basics. The basic thing we're going to do on wounds and teach families to do is to wash them. Wash them with a mild soap and water and rinse. Now, if it's a puncture wound where germs have been pushed down inside and it's not a big open wound where washing it really gets water flowing through the whole wound, then it's better to soak it. Our hope is to get that soapy water down in there where the germs might be. So a puncture wound we would soak for several minutes. If we have blisters, we don't want to open those. And moms are good about kissing wounds. That is not really the best thing to do. That's a good way to add some germs into a wound. What we do want to do is cover any opened wounds. If they're small, then just an adhesive bandage. Your basic Band-Aid is good. If they're larger, we're going to need more of an occlusive dressing. When we put a dressing on, we want to make sure we have a wide margin of intact skin. So the dressing should be much larger than the wound. We want a good margin of intact skin underneath that dressing. And we would remove that wound anytime it's leaking. We don't want moisture getting on that intact skin and causing maceration. When you do take it off carefully though. We don't want to damage the new granulation tissue that's developing. And we want to prevent scratching because that puts germs in there that gets those secondary infections. On infants, you can put little mittens on their hands, or even on a young child, get them to wear mittens. Make sure the nails are kept short, and give antipyretic medications. Give them something for the itching. Okay, bacterial infections. Impetigo. Most of the time this is something that's treated at home. It is contagious. These are the germs that we normally have on our skin. They're usually staph or strep, but somehow they get underneath the skin. Usually there's some sort of a break in the skin, and this forms a crusty yellow crust, and that yellow crust makes it easy to identify as impetigo. So we want to soften up and get those crusts off, and then usually they're treated with either a topical or an oral antibiotic. Cellulitis. The germs are a little deeper in there. They're not just at the skin level. These kids may very well need an IV antibiotic, and which means they may need to be hospitalized. With cellulitis, you often see the lymph vessels become reddened and enlarged, and you get that streaking going up from the site. And sometimes they'll have systemic symptoms, fever and malaise, and just really feel bad. With these, we want to use hot, moist compresses on the area. And I believe we have a couple pictures. There's a cellulitis. Usually there's something where the germs got underneath the skin, whether it's a bug bite or a cut or a scratch. And here's a periorbital cellulitis. These kids we always admit to the hospital because of the location. When it's that close to your eye and your vision could become involved. Viral skin infections. Viral usually means it's one of our common childhood illnesses. In one of the other chapters we talked about different childhood illnesses and the characteristic rashes with those. Things like herpes, varicella, rubella, and rubeola all have characteristic rashes, as does warts. That's actually a viral infection of the skin. Fungal skin infections. These are superficial infections that live on the skin, so they don't go deep and systemic. There also can be called dermatophytoses or tinea, and if you say tinea, that you usually follow that with the location. It's transmitted from person to person by contact or from infected animals to a person. Often kids will get these because they sleep with their kitten or their puppy. Like tinea capitis is on the head, tinea corporis is on the body, etc. And here's some pictures. The common name for this is your tineas. This is ringworm, which there's no worms involved. It's a fungus. Dermatitis. This is an inflammatory reaction of the skin to a chemical. The initial reaction is going to be on the exposed region. And so you'll get a real characteristic delineation between the red inflamed skin and normal skin. You'll get this sharp line between the two, and that's how you know this is a dermatitis. And you can get diaper dermatitis. It can be from plants. It can be from some sort of animal irritant like wool or soaps. I know one of my kids has problems anytime he has something with down in it, a down blanket or a down pillow, and you know the cheek you had laying on that pillow will turn bright red. Drug reactions. Adverse drug reactions are most often seen on the skin, and the most common reaction is a rash. The rash, it can be intermittent. It can be immediate. Sometimes you will get intermittent hives that kind of come and go, but it can be immediate or it can be delayed following the administration of the drug. If it's something you've never been exposed to before, it often takes a while to react, and it can take up to 7 days. If you've been exposed before, then you'll usually get a pretty immediate reaction. We treat this by discontinuing the drug. If this was an IV medication, we would want to stop the medication but keep that IV open. So flush it with saline so that if we need to give something IV to alleviate the reaction, then we have the IV ready. We may need to give antihistamines, and if it's severe, we would go with the steroids, the corticosteroids. Foreign bodies. This is things like splinters. A basic splinter, we can teach moms to sterilize a needle and tweezers and kind of pry open the skin with the needle and pick it out with the tweezers. Things like cactus spines or very small little prickles are hard to get out with tweezers. So one way of doing that is to put some glue on with a gauze over it, let the glue dry and pull it out, or tape. Put tape on, really try and get it stuck on there and pull it off, hoping it'll pull out all those little spines. The small ones are rarely a problem, but if it's large, you may need to see the doctor to have it removed. Or if it's something that's very difficult to see, such as a piece of glass. Arthropod bites and stings. This is spiders and bugs. This can cause mild to moderate discomfort. Usually we manage the symptomatic measures, so putting a cool compress on, giving them something for the itching, an antipyretic, and then preventing secondary infections. So keeping that area clean, not letting them scratch. For bees, the stinger penetrates into the skin, and so we want to get that stinger out as quickly as we can, and usually putting something cool on there, or some the white powder you use in cooking, baking soda, mixed with water into a paste on there is helpful too. Somebody who is sensitized, has a true allergic reaction to bee stings, they can go into anaphylaxis with this. So that person really should carry an EpiPen with them. Black widows and brown recluse spiders. These both usually require medical care, and the brown recluse is actually the worst of the two. Scabies. Scabies are little mite, and the female burrows under the skin, burrows into the epidermis and lays their eggs there. Of course, they also leave feces behind. The person, it'll take anywhere from 30 to 60 days before they really become sensitized to and react to those eggs and feces under the skin, and then they look like they're having an allergic reaction. They have these itchy scabs or hive type things. Usually it's between the fingers or around the wrist or in the elbow, the inner side of the elbow. And to really diagnose it, they've got to take a little scraping and look under a microscope. The treatment for that is to use a scabicide, which is permethrin or lindane, which are also the same medications used for head lice, but with scabies you put it over your whole body, sleep with it on. I believe it has to stay on 10 or 12 hours, something like that, and then you wash it off afterwards. There is an oral treatment, this ivermectin, and that's given as long as a child's more than 15 kilograms, or it can be given. It seems like the topical is used primarily. Killing the scabies is not enough though. You've got to do really thorough house cleaning, washing all the sheets, anything that the scabies might be on. Pediculosis, capitis, head lice. This is very common, especially in school-age children. The adult louse can live, this says only, but I would say this is, only is the wrong word there, can live 48 hours without a human host. So if a louse falls off of one person, it's 2 days later it gets onto you. It still can, if you've got a pregnant female, you now will have head lice. So the female louse lives about 30 days. The female will lay eggs, nits, at the base of the hair shaft. They particularly like above the ears and along the nape of the neck. And the nits look very much like dandruff. The difference is the nit is glued to the hair shaft, where dandruff, if you touch it, it kind of comes off easily. The nit, if you grab it, it'll pull all the way down and off the hair shaft at the end. You can't just lift it off where it's at. The nits take about 7 to 10 days to hatch, and the treatment are pediculicides, which are in a shampoo typically, and then removing the nits. The problem is the shampoos do not kill the nits that are less than 3 to 4 days old. They kill the nervous system, and the nervous system hasn't developed yet in the newest, the most recently laid nits. So you have to remove the nits. You have to remove all of them, or they will rehatch. Those ones, in 7 to 10 days, the nits that had just been laid will hatch, and you will have another infestation. It's also very hard to get rid of this. Even if you do the shampoo, you get all the nits out. Everything that child's head has come in contact with, jackets, the teddy bear they sleep with, the pillows, the sheets, the car seat they sit in, all of it needs to be aggressively vacuumed or washed